Hello. Professor, is it audible? I'm Giri.
Yeah, Giri, you're audible.
Welcome, respected speaker and audience. We will go to the last part of this session.
Hello.
The speaker is KVL Narsing, Professor of Neurosurgery, Nimhans, Bangalore. I invite Dr. KVL Narsing to deliver his lecture on
Okay.
vestibular schwannomas. Dr. Narsing Garu.
Yeah. Okay.
Yes.
The organizers will be happy if you finish in time, sir.
Yes. I know, I'm informed. Yeah, I'm informed. Is my screen is seen? I think my voice and screen is, anybody can confirm?
Yes, Narsing, very well.
Both audible and visible.
Thank you, sir.
Everything is clear.
I know that my talk is in the last session, so I want to be very quick and not to get bored. I'd like to finish within 15-20 minutes. Let me try. So the topic is on vestibular schwannomas. ముందుగా అందరికీ నమస్కారం. ఏపీఎన్ఎస్ఏ ఎగ్జిక్యూటివ్ కమిటీ వారికి, నెక్స్ట్ ఆర్గనైజింగ్ చైర్మన్ రవి గారు, బలభద్రరాజు గారు, లోకల్ రాజమండ్రి న్యూరో క్లబ్ పొద్దు నుంచి వస్తున్నాం. కార్యక్రమాలు చాలా ఎక్సలెంట్ గా బాగా ఆర్గనైజ్ చేశారు. దీన్ని తెలుగులో పెట్టడానికి ఏంటంటే ఇది ఒక చిన్న ప్రయత్నం నాది. అభినందనలు చెప్పుకోవడం, ధన్యవాదాలు చెప్పుకోవడానికి తెలుగు భాషకు మించిన భాష లేదని చెప్పడానికి ఇది ఒక చిన్న ప్రయత్నం. I hope that everybody will accept. Vijay Sarthi is already smiling there. Thank you, Vijay Sarthi, for remembering me in your introduction. So coming to the vestibular schwannomas, I would like to present briefly those important points which are relevant to the surgical practice, day-to-day surgical practice. So they make 8% of the primary brain tumors, and their growth rate is variable, 1 mm to 10 mm. So some tumors grow fast, some tumors grow slow, but most of them, they are basically very slow growing tumors. So there is an important thing to operate them because they are slow growing. They can affect, the disease can affect you in a long term. So that is the fundamental understanding. So we have various sizes and presentations are possible. We know that we can have very small tumors which are restricted to the meatus, and then small tumors which occupy the cistern and touching the brainstem. And of course, the routine tumors which we get in institutes and medical colleges, the big ones. Big ones definitely need surgical interventions, but the rest of the two are controversial areas. So this is the Hanover staging, 1 and 2, they are in and around the meatus. 3 is touching the brainstem. 4 is distorting and affecting the brainstem in a significant way. So coming to some guidelines are there, although it's a controversial area. So hence we have lots of guidelines. This is the recent guidelines which I picked up, European Association of Neuro-Oncologists, which say that we have these small tumors which are asymptomatic, totally in and around the meatus, totally asymptomatic, no hearing loss, no facial loss. Best would be to observe them. The conclusion is that best would be to observe them. Of course, the level of the evidence are 1, 2, 3, 4. 1 is the best evidence. A is the best recommendation. We can't have all these things because we don't have the randomized control trials. So best recommendation is grade 1. We do not have for this, and best recommendation is A. So just bear with me to pick up the levels of evidence here. So asymptomatic tumors, basically, we don't need to do anything, just observe. Second is a small tumor with an impaired hearing. These are small tumors with an impaired hearing. So what we have to do is that the hearing preservation cannot be done with the surgery. So best would be to go for a stereotactic radiosurgery, which offers a better hearing preservation than the surgery. Even facial preservation is also much better with the SRS. So that is small tumors with impaired hearing. We have another set of the tumors, small tumors with a complete hearing loss, in which all the options are justified. We can observe them, we can do stereotactic radiosurgery or operate also. But SRS, being a low risk profile, can be offered with the discussion after the discussion with the patient. So I'm talking of small tumors with complete hearing loss. So medium-sized tumors, here is the real controversy. Here, medium-sized tumors, either you can go for SRS, that is radiosurgery, or surgery. So both are really good because the facial nerve preservation rates are more or less equal, but it has to be discussed with the patient because the tumor control is much better with the surgery. We can go for surgery, but however, stereotactic radiosurgery is also done. This is a controversial area, but the recommendation is only level C. So both are equal. You have large tumors, there's no doubt you go for surgery. Surgical experience actually passes through these 3 phases. First, the surgeon will be low and slow and hesitant surgeries will be done, and then speedy and hasty procedures are done in these tumors. And then finally, you become a confident and a calm surgeon where you will really assess what's going to happen, and ability to feel and perceive the anatomy is much better, and ability to anticipate the complication is much better. So preoperative adjuncts, we have lots, many things are there nowadays, but the most important, which are practically important for us, as well as the patient, is that the cranial nerve monitoring, facial nerve monitoring is the most important thing. I would not like to operate my case if you don't have a facial nerve monitoring or CUSA in the operation theater. Preoperative workup, we all know, most important things to see is the mastoid pneumatization and the type of the sinus. You have a sinus like this, it is very difficult to drill this particular part of the bone. So we have to be seeing the preoperative images very nicely. Pneumatization is important to see because we need to wax the patient intraoperatively after the surgery. Note your sinuses well in the preoperative MRIs. A large sinus is difficult to operate while doing craniectomy only, you may lose the patient. And estimating the level of cerebellar retraction is one new concept which I was having, which I'm practically practicing nowadays, is that you can really estimate what is the amount of cerebellar retraction needed by taking two parallel lines and to see that behind the sigmoid sinus, how much cerebellum needs to be retracted. And after your CSF release, we need to see this much is my extent of cerebellar retraction which is needed. Whether it is feasible or not, we have to see, because if it is not feasible, it is going to be difficult for you in the surgery. So read your preoperative images carefully. This I want to quickly pass through it. You have a preoperative hydrocephalus. Despite a shunting, this is a large tumor which we encountered. You have a large tumor like this. Even if you do a shunt, you have to be very meticulous in seeing that this patient was shunted actually preoperatively. If you see the shunt is there, but ventriculomegaly is still there. So it was difficult during surgery. The cerebellar retraction was difficult. We had all the problems. However, the patient is fine. You had hematomas and retraction problems. Facial nerve could not be preserved in this because you have a tense cerebellum. You cannot do that. But you surprisingly, you see after the tumor removal, the ventricle subsided actually. Ventricle size has actually reduced. So if I had identified this problem preoperatively from the MRA, just all that you need to do is to put an EVD, which can be done, which I'm overemphasizing because cerebellar laxity of the cerebellum is most important for your surgery. So nerve monitoring, I'll quickly go through this nerve monitoring. Without nerve monitoring, I already highlighted that you shouldn't be operating these tumors. We have a Medtronic NM30 monitor here. So we know that at least two muscles need to be selected. The grounding is important. So principle of electrophysical monitoring is that you are stimulating a nerve, which with the electricity impulse will go into the muscles, and you are recording an electromyogram. So what you are recording is actually an evoked electromyography. So when you go into the theater where the facial nerve monitoring is done, if you have a continuous sound like the beep sounds, if they are coming repeatedly, that's called repetitive response. Non-repetitive response, when you stimulate the response will come, it's called the non-repetitive response. Repetitive response occurs when there is a damage to the facial nerve, and it cannot localize the facial nerve. Whereas a non-repetitive response you get when you stimulate the nerve, you get the beep sound. So that way you can localize the facial nerve. So electrode placement is important. What is important? We know how to place the electrodes and all that stuff. What I want to highlight is that you have to gently tap the electrodes once they are put, so that the circuit is complete or not, you will get to know. So this is an important steps to avoid that the entire machine will not be useful unless these electrodes are placed correctly and they are connected well. And the setup, we all know, we put it 100 pulse duration of 100 microseconds and 100 millivolts, monopolar versus bipolar. Just I want to tell you the important electrophysiology, that is when the bipolar, the LCT goes around, and if you have a nerve here, then only it will get stimulated. In monopolar, what happens is that monopolar electrode, when you are stimulating, the electricity passes through a wide area. If there is a nerve in this, facial nerve is in this location, it gets stimulated. But however, the impulse has to be carried by a receptor. So this is important. That's what grounding I was telling. There is a, if you see the monitor properly in the Medtronic monitor, this here, the stimulation is coming from this, and the reception is through this, through this grounding electrode, which is there. So we generally use a monopolar electrode. So the stimulation should be done with adequate intensity and adequate duration. So the purposes we know, to identify the facial nerve, to avoid the injury to the facial nerve, this is being used. Stimulus intensity is important. At the lower levels of stimulus strength, it should be, the outcome is much better when you have the lower intensity stimulus stimulating the facial nerve and you are hearing the beep sound. Navigation, of course, if you are having the luxury of having the navigation, you can use it. Preoperatively, you have to locate the tumor as well as the sinuses, draw the sinuses, and then this is how the registration is done. You identify the points in the facial. In the lateral position, it is very easy to do the registration. And then after the registration, you can identify where is your transverse segments. Predominant use of neuronavigation I found is only the location of your transverse and sigmoid junctions. This is how it is done. And here you can see that the black line and the blue line here, this is what anatomically we thought, and this is what we got it with the navigation. So coming to the surgical anatomy, I won't go into the details, just my resident made this beautiful 3D model in order to understand this three-dimensional surgical anatomy. This is what we should know, the extent of the craniectomy and what exactly we are seeing inside. We should have a three-dimensional understanding. Otherwise, you won't understand the surgery, or you won't be able to perform at a later date when you are operating on yourself. So basically what you are looking is that we have the petrous bone on your left side. You have the lower cranials, 7th, 8th complex here and 5th nerve here. And clivus is in your depth, and towards this side is your brainstem with the tumor. So this is the topographic anatomy. There are 3 groups of the cranial nerves which you get: lower cranials, 7th, 8th, and 5th nerve, we all know. But most important for us to really appreciate is that the lower cranials are lowermost and they're superficial. 7th, 8th is middle, and the 5th is, we encountered the 5th nerve, cranial nerve at the depth. So not only that they are arranged vertically up, means from one above the other, from the depth wise also, lower cranials are superficial and 5th nerve is more deep. So positioning tips, we all know we operate in lateral position. In exams, supine with the head turn was operated in some places, sitting position is done. But this is how the lateral position is achieved. Most important thing is that your shoulders position is important. This I want to highlight, that the shoulder should be pushed more anteriorly so that you don't have any hindrance in your axis. Rotation and lateral flexion is the movement which what you want. So this is how the final position along with the electrodes you get. The suboccipital muscle dissection is actually the injury to the vertebral artery is over highlighted. Most of the times it is not encountered. So you can cut all the muscles safely, but not with the monopolar. It is safe to cut, to develop a plane between the muscles with your scissors and then cut. So the drilling should always be done with a guard in place. So you shouldn't be drilling just without a drill. So this is how the exposure is done. Surgical steps, I want you to observe my surgical steps, which I have practiced over years. Initially, I was doing with retractors. Nowadays, I'm totally doing without any retractor, means long-term retractor on the cerebellum, which will be used during the surgery. So I want you to appreciate that point in these surgical steps, which I'll be showing quickly. So this is the dural opening. What I want to highlight is that your dural opening, first dural opening should be towards the cerebellomedullary system. I have a small video practically to demonstrate where exactly your incision should be given. Towards the cerebellomedullary system should be your dural incision starting point. There are multiple incisions which are described. What is practical is that you should be opening the cerebellomedullary system the moment you are opening the dural itself. Sometimes you can get beautifully the CSF coming there. So, and then only you should proceed for the rest of the dural incision. Particularly the trans cerebellum, it is important that you cut your cerebellomedullary system before. So sometimes if you are not lucky to get the CSF, you have to really go there and open the cerebellomedullary system and release the CSF, identify the lower cranials and the pica there. So next step, we know is to take out the arachnoid layers. Multiple arachnoid layers are already described. What is practical is that never ever see any structure nude. You want to see the 5th nerve, you have to leave an arachnoid. You want to see the lower cranials, you have to leave the arachnoid layer over it. So the technique is that you expose the tumor and leave the arachnoid as much as possible at all levels. This should be the aim of your surgery. So next step is the stimulator checking, which I want to highlight, that when you see that the entire thing is set up, but still you want to confirm whether your stimulator is working or not, is by locating your the lower cranials and identifying and to adjust. One minute. So just I want to show that when you touch your lower cranials, you get a, due to the accident now, that's the moment which you get, which shows that your electrode system, everything is functioning perfectly. Lower cranial nerve separation, which we all know is important. Again, I'm stressing the need to leave the bit of arachnoid there along with the lower cranial nerve. So here I'm showing you that is the layer which you have to leave on the lower cranial. This is the most important step to do, so as to preserve the lower canals, which are important during your surgery. So next step would be to coagulate a small bit of the tumor there. This should be done only after you remove the arachnoid sheath and you take a small biopsy and then go for internal decompression. These are the usually routinely done surgeries. So most of us are very well aware. I'm just highlighting that the biopsy is done, then the internal decompression, then you do this. This is a fantastic job in vestibular Schwannoma. And people enjoy doing this, is that you hold the capsule and then peel off the arachnoid. This peeling, Dr. Suresh Nair describes fantastically. You have to hold the arachnoid and peel it. And you need a very good assistant to do this job. He has to do in a proper direction. This is exactly, I am teaching my resident how the traction should be done. This is called traction and counter traction. So exactly, he should be opposite to the direction of the pull. He should be assisting it. So here I'm trying to teach him where to hold the arachnoid and where to get. Another nuisance which you get is the blood which you have which comes from the decompressed tumor area. And you can use a QSA further. And this is the capsule, how it is getting rotated. This is the brainstem, beautiful brainstem, which gets shiny brainstem, which comes. And this is the step which you have to be careful where you lose your facial nerve more times. This is an old video just to show the internal acoustic metres drilling. Most of the times it is not done nowadays because the facial, you lose it when you are doing this procedure. This is the fifth nerve dissection, is the almost last we encounter. First is your lower cranials, next is your 7th, 8th usually. And the fifth nerve is encountered sometime during the surgery, but usually it is at the depth. So you need to identify your 7th nerve, 5th nerve very carefully. And usually 5th nerve is never damaged because it is thick and you can do it well. This is another vein which Dr. TVR Kemurthy was highlighting in his presentation. This is a petrosal vein, Dandy's vein. You can even preserve it in medium-sized tumors. And most important is that never injure the vessel, the petrosal vein, because there will be tremendous bleeding, and it is very difficult to stop the bleeding. So this is the 6th nerve. Sometimes in large tumors, when there is a prepontine large cistern, you encounter the 6th nerve. This 6th nerve often confused with the 7th nerve. So just I want to highlight that I'm still searching for the 7th nerve. It indicates that this is the 6th nerve, which lies in the prepontine space. So these are some of the important surgical steps and events which we encounter. This is the last part of my video, which shows that facial nerve, once you get identified, you have to be very careful. And here is my last portion of the facial nerve. Along the nerve, nowadays, everybody is leaving the tumor. That's the most important thing, because when you want to dissect this, and this is the 7th nerve, if I have to dissect all throughout this thing, you are 100%, you are to lose it. So you should leave a bit of the tumor around that. The closure along the facial nerve, you should leave a bit of the tumor. Closure, of course, should be meticulous, should be done under the microscope ideally, but if it's not possible, you can do it outside also. But meticulous dural closure is important to avoid pseudomeningocele synthesis of leaks. So this is highlighted here, and close your mastoids. Always check for this thing. This, I just want to show the highlight that I'm not using the retractor even in a large tumor. I just wanted to show that. So this is that video nowadays. Practically, your tumor will help you without your retraction. Many cases I have done without fixed retractor. You can use a fantastic results you can get when you don't use retractors than you use them. So these are some of the post-op scans, 6-month follow-up scan. And you leave a bit of the tumor always to preserve your facial function. And a long-term follow-up is required. See, when you leave a bit of the tumor, long-term follow-up is required. Here you see at the 2 years, the tumor is only intrameatal, which is actually increasing at the end of 4 years. So if you are lucky, if everything goes well, you can have a fantastic facial outcome. Slight deviations, but if you are unlucky, you will get reasonable facial function, no functional impairment. But if you are very bad luck, you will get a picture like this when you have redness already developing with all that noise or nonsense. So conclude, meticulous attention is required at all levels. Reading your preoperative imaging, feeling the anatomy, and anticipating the complications. This is what all is required. Once your surgery goes well, generally the post-op complications are less, the outcome is better. Striving for good outcome is always, Dr. Goel used to say that when you think that the seventh nerve losing is your complication, then only you try for good to save it. And use of technology, of course, whenever needed is important. Thanks for the attention. Hope I have not crossed my time. Thank you.
Thank you, Dr. Narsing Rao, for concluding in time.
Thank you, sir.
I hope the audience are very happy after this hearing this nice lecture. I thank organizers, Dr. Balbhadra Venkatras Garu, Dr. Ravi, Dr. Perumallu Garu, and Varaprasad Garu for giving me this opportunity. And now,
Giri, just I want to say some words.
Welcome, sir. Welcome. Sorry,
sir. Very nice talk.
Thank you.
So you need not worry. It's last talk because of COVID and webinar. All are well attending your and hearing your speech. So usually what happens? So naturally it happens. Last speech nobody will be there. But here a number of people are doctors are hearing your speech.
Thank you.
So it is fruitful, also very useful for residents. So my small this one is initial classification, as you told, now small, medium, and large. What is the size or volume?
The size, sir. The extent of the tumor.
Size, extent, or any size?
Extent.
Previously 3 centimeters, 3 to 6, like that. It is there or only?
If I can go to the slide back, sir. Just a minute. I hope my slides are seen now.
No, not yet.
Not yet. So initially there is no size or anything. You told small, medium, and large. Yeah.
Yes, sir.
So is there any definitions for this?
The definition is, sir, if the tumor is small and in and around the meatus.
Meatus, okay.
That is 1 and 2. Yeah, if the tumor is crossing the meatus and reaching the cerebellomedullary system, touching the brainstem, that is 3.
Oh, yes.
4 is what compresses the brainstem.
Large,
so there is a Hanover. There are so many classifications. Hanover and Coos are.
This is a practical classification, I think. Right.
Yes, sir.
Useful.
Yeah.
Dr. Narsing.
Yes.
Dr. Narsing, this is Vijay Sardi.
Yeah.
I think you have reached the 4th stage of calm and hasty.
Thank you. Thank you so much.
And one more thing is, did you notice any small acoustic resolving a natural history? Do they resolve natural history of small acoustic schwannomas? Do they come down in size over a period of time now that you have a gamma knife in your center?
No. Yes, sir. The one thing I want to tell you that these vestibular schwannomas, when you follow up, they all have grown. I'm yet to see a tumor which becomes small, but it does practically happen when there is a hematoma or bleed, or sometimes it can happen, but I have never encountered it.
Did you come across any complications of radiosurgery, like some?
Yes, of course, many. That's a good question. Actually, there are many times when the size of the tumor is around 2.5 to 3, we go ahead and give the gamma knife. We go and treat with radiosurgery. What happens is that you will have a central necrosis, but over time, actually it grows. And you will have I have seen the radiation necrosis. I've also seen the worsening of cranial function.
No, not worsening cranial loss. About the brainstem symptoms they develop over.
Yes, brainstem. Yes, they do.
That's more horrible than surgery. In fact, they project as if it doesn't have complications. I do have patients who come back with so much of facial pain. Typical, brainstem symptoms, which are, on MRI, everything looks very, rosy, but clinically they'll be having a lot of pain. And one of the worst things that have gamma knife is they don't reduce the vestibular symptoms. They tend to over a period of time, months and years.
Absolutely, I agree with you. The gamma knife over time, now I'm realizing that the meningiomas I'm not at all recommending. Vestibular schwannomas, if their size is small and is not touching the brainstem, definitely you can go for it. But if the size is, if there is no proper CSF cleft and it is even touching the brainstem, I would not recommend it. Of course, there are guidelines. As I told you, the guidelines will say many things, but it is not a good thing to give the schwannoma when actually there is a beautiful understanding to make us everyone aware that when you can preserve, when you are talking of preserving the facial in the sizes of 3.5 and 4 centimeter, it is actually easy to preserve your facial nerve when the tumor size is small. So there is no point in going for gamma knife when you have beautiful surgical techniques nowadays with the microscope and all. It is better to go for surgery rather than radiation.
Thank you, Dr.
So one thing is, I am very thankful to Professor Vijay Sardi, Narsing Rao and TVRK Murthy. They have very long association with the APNSA, even though they settled in Telangana and Karnataka. Hope in the coming years also you will have the same active participation in APNSA.
Thank you, sir. Thank you.
With our,
we are all missing you. Yeah.
Vijay Sardi, Narsing Rao and TVRK Murthy, I think if he is there.
Thank you, Dr. Prasad. Thank you very much for adopting us.
No, sir, it is not the question of adapting. We are all same.
You are permanent life members of APNSA and you have to continue the same support in future also.
Yes, sir.
Sir, one more thing is, I profusely thank all the three speakers because this is almost, these three form the highlights of today. All three speakers, especially the Murthy, Vijay Sardi and Narsing, very simple, very lucid presentation, very simple slides, easy to understand. Sir, alak kuchine, everyone are watching your slides and presentation.
Slides and very useful for residents especially, very practical approaches.
So it is definitely,
right.
Vijay Sardi especially, there is no substitute for experience. మేము చూస్తే స్లైడ్స్ అవర్ ఇయర్స్ కలెక్ట్ చేసిన నేను రియల్లీ ఫ్యాంటాస్టిక్ స్లైడ్స్ అండ్ ఆల్సో నర్సింగ్ వెరీ నైస్ ప్రెజెంటేషన్ వెరీ నైస్.
Thank you,
Murthy also. Thank you.
All three are readily accepting to come over to Andhra and ready to deliver the speeches. Thank you. Thank you, one and all.
I request all to join hall 3, sir, for the